years, quality improvement has taken on different definitions based on where people get their definitions from, whether it's from the manufacturing sector or from the academic environment, for example. And traditionally, we've called the improvement process either QA or QI. In reality, quality assurance, or QA, is the process by which you review information and do some sort of audit in order to determine whether you have a problem of some sort. By contrast, quality improvement is the process by which you actually make positive change in order to correct behaviors that you don't want to occur. But the more recent and the more current trend is either using the term performance improvement or what we term here at Girard Associates as continuous quality improvement. And really, that's the combination of all of those other factors where we are doing complete auditing in a systematic fashion. We're doing the improvement process, but we're also doing all the other smaller intangible things that are actually essential to having a good quality improvement program. If you truly want to make positive change and impact patient care, you really have to get down to the nitty-gritty of the processes that you use in order to improve that function. A good quality improvement program actually has several components. The first and foremost, which many agencies do, is the auditing process. But what we see as a problem with most agencies that do quality assurance or auditing is that they read a run report, for example, and they isolate certain issues and go back to the crews and basically say, you forgot to do a certain procedure or a certain skill, and that could have been bad for the patient, and that's bad. And typically it's followed by some sort of educational remediation or possibly punitive action on occasion. That really isn't the scope of what quality improvement should be. However, that's where most of our effort tends to be in EMS quality improvement programs. The audit process is critical to having an effective quality improvement program. However, the process has to be more than just reading a run report and picking up a couple of items that may have been wrong or problematic and then going about trying to correct them. You really need to have a systematized approach to auditing that run report. What are you looking for? Where do you find that information? How do you determine whether that information is actually accurate or inaccurate? And what to do when there's ambiguity in reading the run report? And how should you process that? At Girard Associates, we have a specific procedure by which we audit the report, enter all the information, demographic information excluded, but all the information pertaining to the clinical care into our database. But at the end of the audit, our auditors apply a scoring process to the call. They look at the potential risk to the patient of an adverse patient outcome based on the behaviors that were done or not done on that particular call. Isolating that risk allows us to determine exactly where we need to focus our efforts in improving the patient care, and by which we also create paths by which we send those run reports down certain paths for various forms of improvement. The more highly critical areas, the level 3 or 4 protocol deviations, will go to a secondary review to the medical director. And the medical director is the one who determines whether the care was appropriate or inappropriate in this case. So that's a brief overview of the auditing function. Additionally, you need to have a proper improvement process. And that improvement process typically needs to start with discussions with your crews to talk to them about the call, what happened on the call, and get factual information. And that goes beyond that to educational programs that you may run for the entire department or individual remediation sessions for individual providers. All of that needs to be properly documented and properly charted in a way that you can use that information for your overall improvement processes as they proceed through the entire step of events. Beyond the improvement process, you also need to tie into your education program using the results of your QI process as well. In our auditing process, we isolate each call to look at the potential causes or the potential highest risk areas for improvement. And to start with the least serious of those in terms of the total volume that we see in our auditing, typically revolves around patient assessment. So oftentimes the basic problem that exists from care gone bad in the street, if you can term it that, is that the patient wasn't properly assessed. Either items were missed or they just, even with a proper full assessment, just came to the wrong conclusion. And by that they end up mistreating the patient by applying the wrong protocols. The next most serious item that we find is delays in patient care. And this is actually very common, and we see it in pretty much every agency that we do audits for, where patients are either extricated to the truck prior to care being started, or once they arrive on scene at the side of the patient, they delay and take way too long to do certain critical skills, such as defibrillation, applying oxygen, or even getting a basic 12-lead EKG, for example. So delays in patient care is a very serious problem and a very common one that we see. Additionally, especially for BLS services, we see a failure to activate ALS. So we'll see EMTs typically go to a scene, and they'll then package, treat the patient, transport them to the hospital. And while all the care at the BLS level was appropriate, the big question is, why wasn't ALS activated for this particular patient? And we oftentimes see that not only with straight BLS services, but on occasion we see that with all ALS services, where paramedics arrive at the patient's side and will BLS a patient to the hospital. And your quality improvement program really should capture that and provide the proper mechanism by which to fix those types of errors. The fourth most common issue is simply protocol deviations, where we see that EMTs and paramedics, even when they know what's going on with the patient, will tend not to either completely and thoroughly treat the patient, or will use most of their protocol but apply it in an improper manner. And most times what we see is a patient, for example, with chest pain, who will get O2, aspirin, and nitrates, and the patient's pain will diminish from, say, an 8 out of 10 to possibly a 1 out of 10, and there's still another 15 minutes to the hospital, but the paramedics fail to continue to treat that patient until full resolution of their symptoms occurs. And again, that's quite a common occurrence. But the number one biggest issue that we see as a problem to determining whether patient care was appropriate or inappropriate in the street is actually documentation. Documentation is a very challenging skill, actually. We don't spend a lot of time on it in the education classes and programs, and most QA processes are looking for patient care activities, but they typically don't spend a lot of time on improving documentation for individual providers. In order to make improvement or change to any one of these 5 items, you need to be able to give each provider their own feedback on how they perform each of these skills in order to make sure that they understand where their weaknesses lie and how best they can improve their performance.